Hello and welcome to this evening's webinar. My name is Ranae von Meding and I'm the Content and Social Media Manager for Thérapie Fertility. I am also a same-sex parent to two daughters through reciprocal IVF, so talking about care for the LGBTQ plus community is one of my favourite things to do. I'll be hosting this evening's event and I'm thrilled to be joined here by our medical director, Dr. John Kennedy. Welcome.
Hello, thank you. So great to be here.
Yeah.
Lovely to do this one. We've done this kind of one before, but I really do think it's your favourite.
It is.
And one of the reasons it's your favourite is that we get to throw it back onto you.
Yes.
And I think what I'd like to do, if we could, is spend a little bit of time on your story and your journey, because I think it's illustrative of what many of the couples and the individuals in the LGBTQ plus community would be considering going through if they wanted to have children. So you, as you said, two children.
Yes.
How old are they?
Almost 6 and 3.5.
Yeah.
The half is very important.
Yes, of course. And tell me how they came to be.
So you've heard this many times
Yep.
before, but so my wife and I have been together for 14 years, and it was never a case of would we have kids. It was just a matter of when would that happen and what would that look like for us. We briefly considered things like adoption and fostering, but very quickly decided that we really wanted to kind of go through the fertility process and have a child that was biologically connected to one of us. When we were coming up towards 2015, year of the marriage referendum, we decided that we were ready to start looking at this. We had gotten engaged, and it was time. So we hadn't really decided how we would, do fertility treatment. We vaguely knew the terms IVF and IUI, but we didn't really know what those things were. We knew we would need a sperm donor, and it's actually funny how we tell this story differently, but my recollection is that we were having a drink one night, and we were, obviously we knew that we both couldn't carry and we both couldn't be genetically connected to our child. And Audrey said, wouldn't it be just so cool if they could take my eggs and take some donor sperm and mix it up and then put it back into you, which sounded completely crazy. But we Googled, and a thing called reciprocal IVF popped up, and we were like, oh my God, this is amazing. What is this? Let's do that. So we did a bit of research, found out that reciprocal IVF just meant that between a same-sex female couple or someone with a trans male partner, you use one partner's eggs, donor sperm, create embryos, and then the other partner carries the pregnancy. So in essence, one is genetically the parent and the other is the gestational parent. Yep. We were very excited, and we went to a clinic in Dublin. We had our consultation booked with one of the doctors. I actually don't know if it was you or not, but it potentially could have been you that we met.
It's certainly possible.
There was a consultant who was very nice and said, this would be quite straightforward to do, and we would love to help you, but we can't because there was no licensing at the time.
Issues. Yeah.
So we couldn't do it. But at that stage, we absolutely had our heart set on doing reciprocal IVF. I very much wanted to be pregnant, and we very much wanted to use Audrey's eggs. So it was a case of either don't do it or go abroad. And we, I think by that evening, true to form for us, or for me, had contacted all of the clinics across Europe and had booked a couple of consultations. And that's how we found ourselves in Spain in towards the end of 2015 doing a cycle of reciprocal IVF.
Yep. And successfully, obviously, ultimately.
Yeah. So I suppose it wasn't successful immediately. We didn't get pregnant immediately. We did create 7 embryos. We had a fresh embryo transfer. I did become pregnant, but had a very early miscarriage with that first pregnancy. And then we went again. We didn't really take any time off. I think there was, a bit of time off to kind of sync up the cycles again, and went back for a frozen embryo transfer. I always laugh about this because I ended up having to go back to Spain for the frozen embryo transfer by myself because Audrey couldn't get the time off work. And again, this is maybe something we'll talk about a bit later about not having leave for things like fertility treatment. So I had to go by myself and flew over on a Ryanair flight on a Thursday, had the transfer Friday morning and flew back on the 6 o'clock flight that evening. And that one worked. And, obviously we didn't go back to that clinic to get the blood test. So we just tested at home, and I think we tested about maybe 7-8 days later, and we were pregnant, and it worked.
Well done.
Yeah.
Well done.
Yeah.
I think that's fantastic. I think it's unfortunate that you had to travel. Had to, because I think it's less unfortunate if you want to travel. I think there's merits to all things, but I think it's really unfortunate when you have to. I'm happy that that's no longer the situation. That reciprocal IVF is now offered by a number of different organisations. That it's not weird or unusual. It's still classified in the eyes of the law by our legislative authority as double donation. Medically speaking, it's double donation, which is crazy, because it means that when we've a couple going through reciprocal IVF and we have somebody who is essentially, it's the wrong word, but it's the word we use, donating their eggs to generate embryos to go into a recipient. Let's say you're using donor sperm as well. That donor sperm is screened to an incredibly high standard because you want to make sure that person doesn't have any infectious diseases or something like that. And there's very, very rigorous screening.
Yeah.
There is screening that goes on for heterosexual couples who are going through fertility treatment, but it's not as rigorous because it is understood that these people are in an intimate physical relationship already, so that risk is already done. But for you and Audrey, we treat you as if, that's not happening. You're just, very good friends. It's crazy.
Just for anyone listening, he's being very sarcastic now.
It's absolutely bananas, and that is something that is going to change. Yeah. So recently as a couple of weeks ago, I had a couple come in to me, and one of them had attended me previously and had frozen eggs in St. Elsewhere a number of years ago. And now she wants to bring those eggs over to us. She wants to get donor sperm. She wants to thaw the eggs, create embryos, and then the transfer of the embryos go back into her female partner.
Sure.
And that's all. I think that's wonderful. I think it's a really great shot for them. But of course, the challenge is she wasn't screened as a donor back then. So what can we do? Well, you can sort it out, is the short answer. What you can do is you can apply the extra screening now. You can make representation of the HPRA, who aren't going to say boo to it, but you already have. We've got the nod to them going, no, we're planning on changing the law on this, so this will all become more reasonable to say, no, you two are in a relationship, so you enjoy the same rights and privileges that a heterosexual couple would as well. So I think that's great that's progressing as well. Yeah. But it is still an odd situation that we find ourselves in with respect to screening. But you get around it.
It's bizarre because it's all like, if bringing it back to me, if my wife had sperm instead of eggs,
well, then we wouldn't worry about it. We would assume at some point you would have been in contact with that. It's crazy because the EU Cell and Tissue Directive, I think 2005, which is still the big bulk of the big framework on which fertility clinics around Europe operate, it refers to partner donation. So in a heterosexual relationship, you're still donating sperm, but you're donating to a cycle. Yeah. But then when you fold in the word donor, meaning donor sperm or donor eggs or donor gametes or donor embryos, it gets incredibly confusing almost immediately. So what we call, it is donation, but it's not donation because it's not a donor. Yeah. So what we need to do is just tighten all of that up and put in some checks and balances and acknowledge the fact that these couples are in intimate physical relationships already. So, the screening needs to be of a standard, obviously, but not necessarily of that standard.
Yeah. In terms of how the landscape has changed, so you've been working exclusively in fertility for like a decade?
Yeah, give or take now. It's coming up on that.
And how have things changed?
Well, the first thing that I'd note, and I don't have data on this, I don't have numbers on this, and I know you'd love that, is that the proportion of same-sex female couples relative to single women has changed. So I think there were a chunk of, in inverted commas, single women coming through for fertility treatment 8-9 years ago who weren't single women. They were in homosexual relationships.
Yeah.
But they didn't want to declare that. They didn't want it on any paperwork or anything like that. So I think that's something that's changed. I think just like in the heterosexual community, for want of a better term, I think awareness has gone up a lot, and I think that people are more aware of. I would like to think that people are more aware of testing and agency and autonomy over fertility and decisions in that space than they were. What age were you when you first started?
How old was I? 27, 28?
So that's like if you're to curve it out, that's extremely young.
Yeah.
For fertility treatment, I would have maybe 5 people in that age bracket.
Yeah.
And I'm talking about egg freeze. I'm seeing hundreds. So it's, and I've seen thousands, but the number of people under 30 who are looking to access fertility services and actually get pregnant, very, very low.
Yeah.
So the problem is, if you only start thinking about this and you spend 2 years thinking about it before you do something, which is about average, then you're more likely to run into problems if you start that little bit later.
Yeah.
Like you were very young, and was it an instant thing that, I guess we should start talking about having kids, or was it a slow burn over a number of years?
I mean, we had been talking about it for a couple of years. Like I said, from the time we met, like I was 21 when we met, but the kind of delay for us actually potentially could have started earlier was, I'm a type 1 diabetic, and I had been diagnosed at 26 and then was advised to wait for at least a year to kind of stabilize the management of that. I think I was 27 when we started, and then I was just turned 28 when I was pregnant.
So you obviously found the person you want to spend the rest of your life with at a young age, which is incredibly fortunate and wonderful and to be celebrated. But most people don't.
Yeah.
Most people find that later in their 20s or in their 30s or something like that. And then they follow the same sort of chronological journey. But of course, it's culminating something an awful lot later. So that's, I think, one of the fundamentals that have changed. I think access to the other thing that's massively changed, and this is relevant to you as well, is our attitudes towards donor sperm. And obviously this has been thrown into sharp relief with the Netflix documentary recently. And I'm not saying that was a common story, not at all, thankfully. But it really does illustrate the attitude that potentially could have been there and was there in the past that isn't there now. So now certainly in Ireland, we've moved away from anonymous donation completely.
What year? Like
that
was
right
up
CFRA.
until
That was
2020.
2020. But most of the clinics had pivoted away from anonymous sperm donation at that point. So now all sperm is identifiable. What does that mean? It means that the child or children, when they're 18 years old, can get the name, date of birth, and last known address of the donor. It doesn't mean contact. It doesn't mean anything more than that. But it does mean that they have something.
Yeah.
And that's good. And it's funny because back in the past, when I started in fertility, there was a tincture of identifiable sperm and a pile of anonymous sperm. So your choice and cost was so much cheaper with anonymous sperm.
Yeah.
And to a hammer, everything looks like a nail. And at that time, when you've got a couple or a woman in front of you who need donor sperm, that your focus has to be, and will always be, I need to get these guys across the line. I need to get them pregnant. What is the fastest, most efficient, most effective way of doing that? And it's to use this anonymous sperm. So you convince yourself of the righteousness of what you're doing because it's all in the name of giving pregnancies and creating babies, and that's wonderful. And just a couple of weeks back, I was in Spain. I was visiting a clinic, and there anonymity is enshrined in law. And it's amazing because attitudinally, they're where I was 8 years ago. And they are not fraterning, and nor can they be. Ideologically, they can't. They have been absolutely told in law it has to be anonymous. So for them, anonymous is the right thing to do. And they've got all kinds of rationalizations for it. Whereas I've pivoted completely around the other way. And I now I don't think there's such a thing as anonymous donation anymore anyway, but that's a whole other medical conversation. But I'm now in a situation where I know, and thankfully have evidence to back up, that identifiable is probably a little bit better. And these are issues that you particularly are going to have to deal with going forward when you get asked these questions. Now, your answer will be on the veins of, we did what we could do at that time. This was the most that could be done. We went there. That was the only place where the creation of you in this fashion was possible, and it was anonymous. And then you're going to go, here, listen, you do yourself a genetic screen, and where you're going to get a whole pile of information. That's what's going to happen there, you know, and you'll be able to find who your siblings are, and all the rest of those donor siblings, all the rest of those other good things. So I think, but for you guys, disclosure is never going to be an issue.
No.
It's a live, ongoing, living process. Your children are probably already au fait with the concept.
Oh, absolutely, yeah. We talk about their conception all the time. We talk about donors. I actually had a chat with Ava recently about donors and you know, and her donor, and she just really gets it, you know.
Yeah.
She's like, that's a person who did a kind thing.
Yeah.
You know?
Yeah. It doesn't have any much. It doesn't have to have much more flavour to it than that.
And it could at some point in her life. It could. You know, I'm not a donor conceived person, so I don't know what that experience is.
Exactly. But I still don't think we've answered what that is either, because I think that is a live and ongoing process. And I do think that there are so many stories out there related to donor conceived children or adults now who have struggled, and it's I think it's premature and presumptive to say, oh no, that's because they were donor assisted. I think it is related to other issues like disclosure and anonymity and ownership of the data and legacy and things like that. So I do think that as we progress, and I think your model is something that's really interesting to look at, what are these children going to be saying, or these adults going to be saying when they're 18 and 20? Are they going to be troubled by where they've come from, or is it just going to be a very organic byproduct of where they've come from?
And I think there's going to be like a couple different generations, you know. So right now we have, you know, for anyone who has seen this documentary called Our Father, there's a huge contingent of donor conceived kids who didn't know they were donor conceived. It was all very dodgy. There was no regulation, you know, it was not great. And, you know, these children, not children now, but they're donor conceived adults now, and they're in their 30s and 40s. I'm sure donors in the sense of the word have been around for forever, but, you know, through clinics, that would have been, what, 70s,
yeah, late 70s, 80s.
So there's that wave of people who are donor conceived, but then there's like my kids, and I feel like the experiences are just going to be worlds and worlds apart.
Absolutely. So exactly to that, and I don't think it's fair to put it all in one bag and go, that's donor conceived, this is how we manage it. I think there's sensitivities that have to, as you say, that go with the generations. And I think going forward, I think the challenge will possibly more for the heterosexual community accessing donor sperm, because they still have that, it's still a decision. Do we disclose or not? Now I know what that decision should be. You should disclose early, you should make it a live process, a live and ongoing process. But they have a choice to make. They can elect not to do that. They aren't hamstrung by the CFRA. Dad's name can go on the birth cert anyway. It's a natural organic function of attending the maternity unit. Whereas for you and Audrey, it's straightforward. What was it? A couple of hours at the courthouse or something like that?
It was not straightforward. It's definitely not straightforward.
I'm sorry. It was. It sounds like tireless, ceaseless years of campaigning right? Just to make this change and build for the future and all these things. So for them, it's going to be more of a challenge. But definitely you've got more options. Definitely those options are better and more likely to be successful now. So once you're in a situation where you will need assistance through donor sperm, for example, in most of these cases, then you should just crack on and get the information. I also think that irrespective of your gender identity or sexual orientation, being fertility aware at a younger age, beat the drum, always really, really important. Getting your AMH check, doing a semen analysis, doing a scan to look at the ovaries, these things are vital and should be done in your late 20s.
So this is the thing, like a lot of people, so most LGBTQ plus couples or people coming in for fertility preservation or wanting to become a solo parent just assume that everything's just going to work because they've never been pregnant, they've never tried to be pregnant. Yes. And we certainly did just assume that everything would be super straightforward. And by and large, it is usually more straightforward because you're not usually dealing with people who have years of trying and repeated loss and whatnot. But that's not always the case. And until you try, you don't know, or until you investigate, you don't know. So if you're, absolutely, like I've never believed more in testing than I do now because...
another convert.
No, but it is like, and if you're looking at someone who's maybe 25-ish and knows they definitely want to have kids, but probably not for another decade, the difference between trying to become pregnant at 25 and trying at 35, if there are any issues there, is like vast, right?
So this is where I've kind of been developing views recently. I think natal women in their late 20s should have fertility checks done. Okay? I think you should have an AMH done. If it's normal, park it, on to the next, don't worry about it. So I think irrespective of where you fall on the LGBTQ plus axis, that's an important thing to do.
Yeah,
okay?
If you've got a uterus and ovaries, get checked.
After that, if you require donor sperm, I would like to see, and I would welcome a framework whereby you could get that donor sperm in a relatively cheap, efficient and regulated fashion from an approved provider.
Yeah.
You could get registered through a system, use that sperm at home to try to get pregnant with what we call ICI, intracervical insemination. Very easy.
Yeah.
Very straightforward to do. I'm not saying the success rates are particularly brilliant with it.
But pretty similar to just intercourse.
Absolutely. You're trying yourself and you can track that through. And then if that does not work, then you come in likes of me. So I think you should get checked in exactly the same way as heterosexual couples should be fertility aware and all that. But you don't necessarily have to go and run the whole gamut of testing. My problem is that that's not an option. This is the unintended consequence, we spoke about this earlier today, of the CFRA, means that while it is now possible for two women to both go on the birth cert, that can only be done when their fertility treatment is undertaken in a licensed premises. So a fertility clinic, an IVF clinic. So you're now being forced to come in. And honestly, this was, I don't think it was really the intention of the legislation. It certainly wasn't ever my intention or the intention of the fertility clinics. I never even thought about it in that context, but it's certainly, I could see from a certain point of view, it looks like I would advocate for something like that. Now you have to come to me, No, not at all. Yeah. The challenge becomes, though, that now you have to come to a fertility clinic.
If you want to both
be legally parents. You have to. That's the only game in town. And once you do that, then suddenly the whole dynamic shifts. Now the costs go up because now you're looking at costs of fertility treatment. The costs of donor sperm go up because there's a whole pile of rigmarole around shipping and ownership and storage. And so then you suddenly start feeding more towards the more expensive but higher yield treatments, things like IVF instead of IUI. IUI, intrauterine insemination, makes perfect sense for people with no history of reproductive issues or infertility or subfertility. Of course it does. It just doesn't make any sense economically. And because the donor sperm is so expensive and the success rates with these treatments are so much lower, especially in younger populations than IVF. IVF has got better, IUI hasn't.
So just to give a bit of context to that, with an IUI cycle, you would use the same amount of donor sperm that you would in an IVF cycle.
Yes.
But in the IVF cycle, not only are the success rates higher, but you also have the chance of potentially creating extra embryos that you could then freeze. So potential
would be
for
automatically frozen as part of the cycle, and then other bites.
So potentially, now not saying that this is ever guaranteed, but potentially you could have more than one pregnancy from a single cycle.
So
of
the
IVF.
purpose of the testing is to see where we think, we don't always get it right, you're going to fall in this. Am I going to get 5 eggs, 10 eggs, 15 eggs, 20 eggs? Am I going to get 1 embryo, 2 embryos, 3 embryos, 5 embryos from an IVF cycle? Paradoxically, the cohort of same-sex couples that I actually recommend IUI for are the people with diminished fertility.
Interesting. Is that because they potentially won't get as many embryos from...
Or eggs. I think... So look, part of what IVF brings to the table is the weight of numbers. So if I can get 12 eggs, this is a little bit reductive and not quite statistically correct, but for the purpose of the conversation it'll do. I'm looking at a year's worth of fertility compressed into one go. If I can only get 2 eggs, I'm looking at 2 months of fertility. So straight away you can see the success rates on that will be different. So if I've got somebody who's young, who's got a very diminished ovarian reserve, and I think no matter what I do, no matter what I give them, they're only going to produce 1 or 2 eggs, then they can do, then their success rate with IUI is now the same as their success rate for IVF.
And it's cheaper.
It is cheaper, so it's still like perhaps not as efficient as good IVF, but you can do 3 IUIs for a little bit more than 1 IVF, and you've got 3 times the chance. Now, unfortunately, it does mean the corollary of that is that your chance of success with IVF is low, and the real challenge with that cohort is that they do a few IUIs and it doesn't work because sometimes they don't work.
And then you do IVF.
And then they want to do IVF. You're going, no, the whole reason we did this was that so you wouldn't do that, but there's more closure with IVF. But you have these conversations at the front end. But what you have to do is kind of trust that the person you're talking to just wants to get you in and through and out the other side as quickly and efficiently as is possible. Because that's the best thing for you to do. Nobody in their right mind, I've said this before, wants to come and talk to me.
Yeah.
You know, nobody. Of course you don't.
Yeah.
But at least there's there's a clinic to talk to. There are ways you can do this. But just get in, work hard, get out. But just today, I had a conversation with somebody who I had a whole conversation with. I think statistically they're better off probably doing IVF than IUI. They want to do IUI. I'm not going to stand in her way. Of course not. You know. Yeah. So we'll organise that for her. You know.
And do you get many same-sex couples coming in just really set on doing a couple of cycles of IUI before doing IVF? So
this is the tremendously demoralising bit. I would see an awful lot of couples who come in saying they're going to do, coming in thinking they're going to do IUI, and they're leaving going, it's given us a lot to think about. And as I said, that used car salesman, because it looks like I'm pitching up to a more expensive thing. It really does look like I'm trying to upsell, but I'm not. So what I do is I just say, look, I've declared my bias. I prefer IVF to IUI because of how and where I work and how I do and the success rates I look at. And I don't stand in somebody's way if they want to do IUI, not at all. But I want to make sure. I've seen too many couples over the years who've done negative IUI and all they've got to show for it is frustration. And it can be really, really frustrating. It is less frustrating if you know it can be frustrating. But I've spoken to people and we did 3 IUIs and it was only after we did the 3 IUIs that we realised the success rate was low and we feel like we've wasted those 3 months. Yeah. And all you can say to those people really is, okay, look, I know you feel that way, but at least that 3 months has given you the clarity to do this thing now. So let's just
You're
go
in the right
here.
space to do it now.
Absolutely. So wherever you go, there you are. But it is a challenge. And
explain to me, why is IVF a test as well as a treatment?
So when you do IUI, you put the sperm in and you trigger the release of the eggs. And after that, you lose sight of it. You don't know if the egg was released. You don't know if the sperm met the egg. We do a whole pile of tests on women, we look at AMH, we look at antral follicle count, we look at thyroid, we look at rubella, we look at their full blood count. You know, we're looking for infectious diseases, the whole 9 yards, which are very, very comprehensive. And nothing in there tells you about their egg quality. Nothing. Sperm, we can, with reasonable degree of accuracy, look at the sperm quality, and there's destructive tests we can do on the sperm to give us an even better look at the sperm quality. What a waste of sperm. Fortunately, it's easy to get more. Men are generous with it. Eggs are not like that. Eggs, is really, really difficult to tell what the quality of an egg is. Essentially, you, I, everybody else around here, we all came from a good egg. That's why we exist. Bad eggs tend not to give babies. Good eggs do. And most eggs that human beings produce aren't good eggs. That's why fertility rates aren't higher. That's why spontaneous conception rates aren't higher. That's why miscarriage rates are higher. Especially in human beings. We're walking around our hind legs, we're living into our 70s and our 80s, you know, and we're starting our families later. So that has a huge knock-on effect on egg quality. So egg quality is the be-all and end-all. It's the alpha and the omega of fertility success and failure. There are other factors, but it's easily the single biggest, most important one. And we don't know what it looks like. It's terrible. The way we assess if an egg is good is by taking that egg out, fertilizing it, and seeing what kind of embryo it turns into. Now, even that's limited. You're looking at the entirety of a human being based on 5 or 6 days. It's not brilliant. There's other genetic tests you can do that are of variable value depending on your circumstances. But by seeing what kind of embryos you can make from your eggs, you get a much better idea of egg quality. So I just did a transfer on her today, and I had thought we were going to get about 12 or 13 eggs from the cycle. We only got 8 eggs. But she has 5 embryos. So it's a real swings and roundabouts kind of thing. You know, we got less eggs, but the eggs look really good now because she's got 5 really strong embryos and she'll probably knock it out of the park. And you can see some people, you get 20 eggs and you get nothing to show for it, unfortunately. So if I do a cycle and I get 2 eggs, it's very hard for me to make sweeping judgments about that person's overall egg quality based on a sample size of 2. But it's some information, and you use that, and the best predictor of future success is previous success, and future failure is unfortunately previous failure as well. So you do get more information, and one useful exercise that I would often do on people who've maybe been to other clinics or had multiple rounds is where, and it's not a fair exercise, but it's a good mathematical exercise. Let's say they've had 5 cycles over across 5 years. What you do is you tot up the sum total of all the eggs. Then you tot up the sum total of all the mature eggs, all the fertilized day 1 embryos. The blastus is the day 5 or day 6 embryos they generated, the number of pregnancies they had and the number of babies they had. And you break all of that down as a single string of digits. And it can be, for those people who've gone through a lot, it can be an incredibly powerful exercise because you never quite join it all together. Look, realistically, I know on each cycle you've produced so many eggs and it looks good here and this cycle is better than that cycle and all this. But if you take a step back, you go, we've looked at 70 eggs. You've only produced 3 blastocysts and no baby. That is a major egg quality issue right there, whatever way you break it down. You know, and that kind of conversation can be very important to give people clarity over expectation management going forward if they do another cycle, or indeed maybe to get them off the merry-go-round and gone on to do something else, be it stopping or egg donation, or in the case of the same-sex couple, right, we need to park you, we need to look at you. You know? Yeah,
absolutely. So a question has come in that I'm going to pose to you. It's a bit of a tricky one, but it's something that we've talked about before. Okay. So the question that has come in is, you've mentioned infectious diseases. Why will no clinic in Ireland help people who are living with HIV? Okay, when we know that people on effective treatment whose viral load is undetectable cannot pass the virus onto a child.
That's a really good and reasonable question. So the first thing we're stymied by is the legislative requirements. So, and this sounds like I'm hiding, and I am a bit, and I'm going to address that. Okay. The legislation in place mandates that it doesn't distinguish for the purposes of embryo storage and embryo creation and gamete management, that's eggs and sperm management. It doesn't differentiate between somebody who's HIV positive with an undetectable viral load, who's on PrEP and who's perfectly well, and somebody who's, you know, massively immunocompromised who's shedding virus everywhere. So it doesn't differentiate. So it should, but it doesn't. We see the problem far more commonly in hepatitis. So there's plenty of conditions. So we know if you're exposed to hepatitis B, you will always be core positive. Hep B core antibody positive, but that doesn't mean you're infectious. But if we're managing you, we have to store your embryos in a different tank. We need to have different processes and all the rest. Think of it like a halfway house.
Yeah.
The problem fertility clinics have is if you are going to look after people who have a positive result for an infectious disease, be that hepatitis B, hepatitis C, or HIV, who have certain key markers that are positive, irrespective of what that means for their actual infectivity status, then you have to change your process. You have to have a whole separate process. It's not quite a separate lab, but it almost is. Everything needs to be done separately. Everything needs to be done separately, and the costs ramp up enormously. Yeah. And they do, and it becomes a cost issue. And it becomes an enormous body of work for a very small number of patients. So, if you're looking at this space, should these people be looked after? I mean, of course they should be looked after. Who should be looking after them? Well, with the best will in the world, what we're doing at the moment is private medicine. There are 3 companies in the 3 countries in the Western world, in the developed world, which don't offer publicly funded IVF. We're one of them. Ooh, yeah. Now, that is not to say that other countries aren't constantly rolling back on their public funding models for fertility treatment. They are. We know the UK is a postcode lottery, but especially for these people, and they are very small numbers, but they're not edge cases, but they are there. They need to be managed. There needs to be, that is absolutely one of the roles where there needs to be public funding, and that's what I would suggest. On a personal level, would I like to manage these people? Yeah, but I also don't want to charge them twice as much as everybody else, because I've got to hire an extra team of embryologists. I've got to get an extra tank. I've got to change the workstations. I can't have any other egg collections within a time frame. All for nonsense. There's no actual risk here. Yeah. You know? But that's it. So talk to your legislative bodies, get people to grow up to the fact that just because this test is positive doesn't mean there is a risk. So if you have somebody with an undetectable viral load, is there a risk to putting their embryos in a tank with other embryos? Everything would say no, there isn't, but I'm not allowed to do that anyway. I'll lose my license, we'll get shut down. Yeah. So I don't know if that's an acceptable answer. I suspect it's not. It's an honest one. It's as honest as I can be about it. It's not an ideal situation. I've had couples and women I've referred over to the UK and the centres, and we'll give you names and all the rest. You're still paying for it, but you're paying for it in Ireland anyway. You know, so you're going to have to pony up the cash irrespective. It's not your HIV or hepatitis status that's restricting your access to fertility at that point. It's a costing.
Yeah. Thank you. Yeah. So another question that's come in, slightly different question is there any evidence to suggest any specific supplements or diet lifestyle changes would improve egg quality?
So, never been asked this before. Right, touched on egg quality earlier, said it was the be all and end all, so it's the holy grail. If we can fix egg quality, we can fix everything, right? So what determines egg quality? 3 major factors: age, ovarian reserve is a factor, and the third factor is weight. So if your BMI is very low, your cycles may stop, and that can have an impact on egg quality and hormonal dysregulation, so put some weight on. Much more commonly, if your BMI is high, that has an impact on egg quality. It has an impact on everything else as well. In fertility clinics, we tend to be, I try not to be, we're trying to be different. We tend to be paternalistic and to get the fat out of our ears. I say, look, it didn't work. I had one poor woman today, just did a scan on her, and she was saying she'd done a negative cycle of IVF. She in somewhere else, and had been through a public system somewhere else, and she'd been told that the reason she didn't make any blasts was because of egg quality, and the reason her egg quality was poor was because of her weight. And there's a lot to unpack there, and this was a woman who would concede, and this is me saying this, her BMI is high, but she's also lost 8 stone in the last 3 years.
Wow.
So it's a crappy thing to do. She also has a history of polycystic ovarian syndrome. So that makes losing weight even harder, and it does make it harder, you know. And whatever about the great unwashed out in the community fat shaming you probably don't need it at one of the most vulnerable points in your life. There are ways of saying this. There are ways of sensitively having these conversations and managing these situations. And there's also ways of working with people, not against people. So there are the 3 factors. Weight being an important one. Yes, your weight needs to be trending in the right direction. Yes, a high BMI will make egg collection more challenging, will make sedation more challenging, will make access and everything we do a bit harder. That's our job. If we can't do it, we'll tell you. Okay? But that's our job. That's on us. It's not on you. It's on us. If we take you on, we're taking you on. Beyond that, being sensible. Now, I don't know if I'm finding the right pitch here. Because for a long time, through all the podcasts, I've been saying, look, be sensible, make smart choices, and, you know, live your life. You don't have to be a hermit, you know, but just be able to look back and make smart choices. And then I had somebody say to me last week, but, you know, you don't advocate for any lifestyle stuff. I go, that's blast, I've been too soft. You know, I'm not saying that.
I guess people just have different interpretations of what being sensible looks like, right?
Yes. So, and I think there might be a bit of people hearing what they want to hear. You can't binge drink. You can't even drink that much, but you don't have to stop altogether. You don't have to cut caffeine out of your diet completely, but you got to throttle it right back. I have 2 cups of tea a day. What are they? They're liter mugs. Come on, man. Like, you got to be honest with yourself. And I think the vast majority of the people I'm talking with they're plugged in. It's not that they don't know, you know. Obviously don't smoke. Obviously get exercise.
Does smoking have a huge
negative impact? Yes. Yeah, it's tougher to say it has a negative impact on eggs, although it definitely does. But
you know it definitely has a really bad impact on sperm.
Oh, hell yeah. Absolutely. It's murderous, and THC is murderous on sperm as well, or can be. It can be very bad for elevate DNA fragmentation. So that's something, you know, to be aware of. So you need, when I say be sensible, you need to be righteous. You need to be maybe a little bit, pull yourself together. And there's a couple of different reasons for doing that. And a lot of it is so you can look back and say, we did everything we could on this cycle. We left it all out there.
I know the last thing you want to do is to look back on a cycle and think, I shouldn't have gone out that night, or, you know.
This is it, you know, and just equally, I wouldn't ever dream of saying something. Well, it didn't work.
Well, that's why. You
did go out on that night out. Sorry, you know, and just leave it hanging out there. But so I'm not saying that. There's a middle ground that can be explored here, where you can live a life, because this can drag on for too long for you to be on the wagon for that length of time, and be so ascetic for that length of time. But you need to be sensible. Is there a specific diet? Is there a specific supplement? To answer that question, folic acid is necessary. Vitamin D is probably a good idea. After that, everything else is a food additive. It is not medicine. It's a food additive. So if your diet is healthy and balanced, then you probably don't need any multivitamins. Nobody wants to hear that they don't need multivitamins. Everybody wants to hear that multivitamins are good for them. But every big study I've looked at, inside and outside of fertility, says that multivitamins really aren't that useful. They aren't useful for people who've just had heart attacks. So if they're not useful for that cohort, you know, you've got to think rationally about this stuff. So, but nobody wants to hear that.
And you talk a lot about, you know, it won't do any harm, might do some good, sort of thing.
So, and I think that's the rationalization for an awful lot of things. Won't do any harm, might do some good, so off you go. And also, it's exhausting telling you something you don't want to hear. And you're just going to go and take the supplement anyway, so you might as well do it with my blessing, right? And so that's how we've fallen into this situation. That's how we fall into a situation where, well, my doctor told me to take the multivitamin. And then you think back, well, maybe the doctor didn't actually say take a multivitamin.
They just said, okay.
Okay, fine. Yeah, take the multivitamin. Yeah, won't do any harm. Off you go. Yeah, probably not a bad idea.
Yeah.
Just, you know, geez, that's lunch. You know, and I'm not saying that's the right way of doing things, but it's so hard. Believe you me, I know it's so hard to constantly be holding the line and saying, no, that's not where the value lives. What has happened, and especially what happens in fertility, is before you know it, you're on 20 different tablets. You blink and you're on 20 different tablets, because everybody's recommending adding in something, because it won't do any harm, because it might do some good, because their anecdote, their journey revolved around that tablet, that specific brand of that specific make of that specific vitamin.
And that's why it worked.
And that's why it worked. And suddenly you're on 20 tablets a day. And now suddenly there is harm being done. Suddenly you're spending 120, 150 bucks a month on supplements. You're terrified of missing a dose, and you hate filling a cereal bowl full of pills every morning.
Yeah.
But you're too scared to stop.
Because if you stop and it doesn't work,
and
you blame
everybody
yourself.
else is too scared to tell you to stop as well. And your healthcare professionals are too scared to tell you to stop. Because there's another healthcare professional down the road to say, oh no, you need that.
Yeah.
You need that. And you will cleave to certainty.
Yeah.
Like a drowning man will hang on to anything. You will hang on to the certainty you give. So as opposed to me, who's being mealy-mouthed and wishy-washy about the whole thing, hell, go talk to the person who goes, you need DHEA. DHEA is great. Meanwhile, I'm saying, look, I can't be certain, but the evidence says not really. And it's, I'm kind of talking out of both sides of my mouth. I understand why you might opt to listen to the certainty, but it doesn't make it right.
Yeah. Let's go back to donor sperm.
Yep.
In terms of extra steps for people in the LGBTQ plus community going through fertility treatment, there isn't one extra step that you have to take if you're using donor sperm. And is implications
anybody
counselling.
Who's using donor
Yes,
sperm, not
absolutely.
just the LGBTQ plus community, but anybody who's using donor sperm or donor eggs has to do what's called implications counselling. It is not a sanity test. It's not a test to see are you fit to be a parent. Nobody gets the little mark put on their
little
on
gold
their
star.
notes or
Or a big X.
Yeah, big X going, not so sure about this one.
So
that
what
just
is it?
doesn't happen. It is there to talk about, never use the word in the definition of the word, is there to talk about the implications of the choices you are making, to talk about some of the challenges that you may be facing over the coming years, to answer some of the most commonly asked questions, generally around disclosure, when, how, who, what resources are there? Are you the first person to ever do this? Who else has done it? What's been their experience? Where did it go right for them? Where did it go wrong? There is a wealth of information all of this out there. So what implications counselling allows is to aggregate that information, to put it in a digestible form, not to give you the answers, but to tell you how to go about getting those answers and how to go about asking the right questions. Oftentimes it can feel a little bit redundant for many people who've known for a long time they were going to be using donor sperm. They say, no, I have considered all of this. Yeah, but you probably haven't, to be quite honest, because, you haven't walked a mile in the shoes. And it is, I've actually, you say it's very unusual, but I haven't actually met anybody who's actually come out and said, that was a colossal waste of time. I wish I didn't have to. They go, you either get, that was very useful, or you get a grudging nod.
That was grand.
No, it was fine. Look, yes, I can see why. Fine. Yes. And it's online. It's 40 minutes.
Yeah.
It's a once-off thing. It's an easy thing to do.
Yeah.
Now, what is going to happen outside of the LGBTQ community, and it's going to affect this community as much as it affects everybody else, is they're talking about bringing legislation which will force everybody to do another session of counselling, which is centres around, have you thought about the implications, not implications counselling with specific donor sperm, but just the implications of going through fertility treatment. That means I am not in favour of that.
Yeah.
I think counselling should be readily available, and we should be supporting people going through it. And I think access should be probably earlier than it is a lot of the time. Of course it should. But it's stigmatising, and it's unfair, and it's discriminatory to make
people.
everybody do it. Yeah.
One more question before we finish, and this is more from my kind of personal interest. So sometimes when you get a couple going through treatment, and it could be a heterosexual couple, it could be an LGBTQ plus couple, who are using donor sperm, and especially if it's one person going through the treatment using the donor sperm, and the partner can feel outside of that journey, out of that process. How do you find people in the day-to-day, how they deal with that? Do you find that people do well with it?
I think most people cope better with it than they think they would. Certainly for men using donor sperm, they, as a cohort, I've often felt have done way better than I thought they would. They've bonded readily and easily. They don't have the attachment issues you would expect because, as you say, they're so divorced. the person who's not going through the fertility treatment is divorced from the fertility treatment. Okay? And that doesn't, that, even if you're using your own sperm or you're using donor sperm or you're just going to be the recipient down the line. Now, yours was a fresh transfer the first time. So it was a, I won't say seamless process, but it was an ongoing. There wasn't actually a break per se.
Yeah.
So everybody who is not going through the
Actively
stimulation
going through it,
and egg collection and potentially embryo transfer or IUI or trying to get pregnant feels fairly functionally useless. And they do. And that is a common thread because it's accentuated, I'll grant you, in situations where you're using donor gametes as well, donor sperm. But they feel functionally useless. And they also feel a lot of the time perhaps like they're not entitled to emotional or psychological pain because they're not doing the heavy lifting. And sometimes I think clinics and healthcare providers can be guilty of ignoring their emotional and psychological pain, especially for a lot of guys who would be stoic and, you know, crush it down deep, you know, and that's where it won't cause any problems. Instead of just taking a minute to acknowledge that they are an integral part of this journey, that you are more than a support system for her who's going through all the treatment, that you are alive and living, an integral part of the whole experience, that without you, this experience can't happen in this way. I think that's really important. I don't think we do it enough. I'll put my hand up on that, but we're trying. We're trying to share, and I think COVID also kind of threw a bit of a spanner in the works there with not letting partners into various places, and it's another nail in the coffin, isn't it? Where you're just, oh no, look, or you can come in and give a sperm sample, then you're done. Your work here is done. It's a casual throwaway joke, but it's reductive, and it's probably not fair.
Okay, so I think that's all we have time for.
Sorry. We get to half of the stuff I wanted to talk about, but it's been fun, as always.
As always. And thank you, everyone, for tuning in this evening. If you have any questions, as always, please fire them over to us on our Instagram. Make sure you subscribe to our podcast, Fertility Talks, and sign up to our newsletter so we can keep in touch about any upcoming events and webinars. So thanks again. Thank you, John. And we'll chat to you soon. And happy Pride Month.
Recording stopped.